Welcome. In this session, we'll discuss subcortical anatomy, including the basal ganglia, the internal capsule, and the thalamic nuclei. This session will complement the Gross Brain Lab 2, dealing with coronal and horizontal sections. In this session, we'll address the anatomy and function of the 5 basic nuclei of the basal ganglia, including recognizing these structures on various brain sections and MRI images. We'll also look at the corona radiata and the internal capsule, which include major sensory and motor pathways, and look at the somatotopy in the internal capsule. We'll look at the direct and indirect pathways of the basal ganglia and how those basal ganglia disorders, such as Parkinson's disease and Huntington's chorea, affect these pathways in selective ways. And then we'll look at the anatomy of the thalamus and the main thalamic nuclei and the brain regions that they connect. Finally, we'll look at the blood supply to the different regions of the basal ganglia, thalamus, and internal capsule. The basal ganglia we'll see are extended structures that include deep in the brain the caudate nucleus and a variety of other structures, the caudate, putamen, and some structures deeper in the brain, and that is the substantia nigra and subthalamic nuclei. We see them listed here. Within the cerebrum, we have the caudate nucleus, the putamen, and the globus pallidum. Within the diencephalon, just below the thalamus, we have the subthalamic nucleus, and in the midbrain, we have the substantia nigra. This whole system is predominantly involved in motor control. We see those structures in this section through the brain, and we can see the caudate nucleus, that is the head of the caudate nucleus right here. We see the lentiform nuclei, or nucleus, which includes the putamen and the globus pallidum. And we can also see the tail of the caudate nucleus right here in the next to the ventricle. We'll also see this dark stained structure, the internal capsule. And this is the posterior limb of the internal capsule, the genu, and the anterior limb of the internal capsule. The internal capsule contains important fibers between the cerebral cortex and deep structures, especially the thalamus, which is located right here. This is the thalamus. We notice that the putamen and globus pallidum are immediately adjacent to one another, and we see them right here. And blown up a little bit more highly, we can see the putamen and the caudate nucleus, which are referred to as the neostriatum. And we can see the lentiform nucleus that include the putamen and the globus pallidum, 2 parts of the globus pallidum, the external segment and the internal segment, the globus pallidum, pars interna. We can see in this drawing the outline of the caudate nucleus, the head of the caudate, anteriorly, the body, and a long rolled tail that follows the lateral ventricle. Right here we see the putamen. If we see it from below or from above, we can see the caudate extended structure and the putamen. Here we see that C-shaped structure in a dissected model where we see the head, body, and tail of the caudate nucleus. In an unstained coronal section, now we see that the caudate nucleus bulges into the lateral ventricle, and we see also the putamen, and between the putamen and the caudate nucleus, we see the anterior limb of the internal capsule. If we look at a dissected specimen from a lateral view, we can see axons, myelinated axons that form the corona radiata. It's a fan of myelinated neurons that go up to the entire cerebral cortex, from the frontal lobe all the way to the occipital lobe, and it carries fibers from deep structures, both from sending fibers down to the cortical, into the cortical spinal tract, coming from a motor cortex down into the cerebral peduncle, and a narrow portion where it all comes together is the internal capsule. We also see optic radiations of the axons that are going from the thalamus over to the occipital cortex. The internal capsule is this dense area that all of these fibers from the corona radiata come together, that include the corticospinal tract, going down to the spinal cord, corticobulbar tract, going down to the brainstem, carrying motor fibers. Those are the upper motor neurons. We see also in this dissected specimen the anterior posterior limb of the internal capsule, as well as portions of the internal capsule a little bit posterior to that, and that is the retrolenticular and the sublenticular portions of the internal capsule that carry information out to the visual cortex in particular. These fibers also carry information from the spinal thalamic tract, from the thalamus up to the cortex, and from the dorsal column lemniscal pathway that carries information from the thalamus up to the somatosensory cortex. We see in this coronal section of the internal capsule, you see this wide range of white matter, subcortical white matter, funneling down to the internal capsule. And we see the internal capsule here just lateral to the thalamus. And we see that those fibers of the internal capsule come down into the brainstem where they form the crus cerebri in the midbrain. And as they come through the pons, they're embedded within the basis pontis. And as they come into the medulla, they're embedded within the pyramid. This shows the fibers of the corticospinal tract. Here we see the internal capsule on an axial view, and we see the anterior limb of the internal capsule, the genu or knee of the internal capsule, and the posterior limb of the internal capsule. And this posterior limb is just medial to the putamen and just lateral to the thalamus. So this very important posterior limb carries information about corticospinal tract information going downwards, and thalamocortical fibers going upwards to somatosensory cortex, as well as, more posteriorly, radiations to the visual cortex and to the auditory cortex. This identifies some of those structures that are part of the anterior limb, and that is fibers that are coming from the thalamus to the limbic regions that we'll discuss in the future, as well as ventral anterior portion and ventrolateral nuclei of the thalamus. And they're important as part of the basal ganglia and cerebella pathways. It also contains some corticopontine fibers from the frontal cortex. The internal capsule, again seen here, has a number of features that we see represented, and that is the anterior limb and the posterior limb. That corticobulbar fibers are located right at the genu, and those are involved in motor functions to the cranial nerve nuclei. And then the corticospinal fibers that are a little more posterior, and they include arm, trunk, and leg, with the arm more closer to the genu, and then the trunk and the leg is most distant from the genu. That posterior limb, as we said, is very important, containing corticospinal fibers, as well as ascending thalamocortical fibers from ventral posterior medial and ventral posterior lateral portions of the thalamus, carrying information from trigeminal sensory neurons, as well as the dorsal column lemniscal pathway for vibration and position, and the spinal thalamic pathway for pain and temperature. That is, after they synapse in the thalamus, they travel up through the internal capsule to the cortex. Somatotopy is important in all of those, represented both medially the arm is represented medial and the leg more lateral, with the trunk in between. We use the acronym HAL for head, arm, and head, arm, and leg to show the distribution of the somatotopic representation in the posterior limb of the internal capsule. We see that represented here again, the head, arm, and leg in the posterior limb of the internal capsule, and then for different parts of the motor and sensory pathways, as well as more posteriorly, the thalamocortical inputs to the temporal lobe for audition and to the occipital lobe for vision. We see these structures represented together again, the internal capsule, anterior limb, posterior limb, and we can see the caudate, putamen, and the globus pallidum, and we see the thalamus in red.
Gain an appreciation of the three-dimensional arrangement of these structures, we're going to peel away the cerebral cortex and the underlying white matter to reveal the basal ganglia and the internal capsule. And we're going to rotate, and we see here some of those structures. We're going to rotate it so we look at it from a lateral perspective. So we're looking here at the putamen. This is anterior is on the left, posterior on the right. We're looking, as we went through the white matter, we first come to the putamen, and then if we peel away the putamen, we come down to the globus pallidum, which is deep to the putamen. And then if we peel away the globus pallidum, we come down to the internal capsule, these fibers that are coming up from the thalamus, or going down from the thalamus up to the cortex, or from the cortex going down to deep structures. And then if we peel away the internal capsule, we see the caudate, the head, the body, and the tail, and we see the thalamus.
We now see another structure that's portion of the basal ganglia, and that's the subthalamic nuclei. So we have the putamen, the globus pallidum, pars externa and pars interna, and then we see the subthalamic nucleus just below the thalamus, and that gets input from the globus pallidum. We now see the final portion of the basal ganglia, and that is the substantia nigra. The substantia nigra, and we see here we're in the midbrain. In the midbrain we see the red nucleus. Also in the midbrain we would expect to see coming out of the this region the third cranial nerve. And then just lateral to the red nucleus we see the substantia nigra, pars compacta, and pars reticulata. And this is the crus cerebri, and sitting right in the crus cerebri portion of the corticospinal tract right here, and corticobulbar tracts right here.
The circuitry of the basal ganglia include principal inputs that are excitatory ones coming from the cerebral cortex to the striatum. The striatum is the caudate putamen. The principal outputs are from the globus pallidum and substantia nigra, pars reticularis, to the thalamus. From the thalamus, they relay back to the cortex. Most of the connections are ipsilateral. But if you have damage to these regions on one side, it ends up causing symptoms on the opposite side because it sends inputs up to the motor cortex, and the motor cortex controls the contralateral side of the body. Together with the cerebral cortex and VA-VL nuclei of the thalamus, that's ventral anterior, ventral lateral, the basal ganglia are interconnected to form two parallel but antagonistic circuits known as the direct and the indirect pathways. Normally, there is a balance between these two pathways which control fine tuning of movements so that it is fluid, but they do not directly control the strength of a movement. As seen here, the overall circuit of these basal ganglia are an input from the motor cortex to the basal ganglia, and then from the basal ganglia into the thalamus, VA and VL, and then from the thalamus up to the cortex. Since the basal ganglia control the ipsilateral motor cortex, it therefore influences the contralateral body. The direct and indirect pathways both use a process known as disinhibition to mediate their effects, where one population of GABA inhibitory neurons inhibits a second population. The disinhibition results in a net excitation of a third neuron. Two negatives yield a positive. Thus, activation of the direct pathway results in an increased cortical excitation and the promotion of movement. Activation of the indirect pathway results in a decreased level of cortical excitation and a suppression of movement. Now, dopamine neurons from the substantia nigra pars compacta project up to the striatum. The dopamine drives the direct pathway through D1 receptors, and that increases movement. Dopamine inhibits the indirect pathway through D2 receptors that also result in a net increase in movement. That is because the dopamine has an inhibitory input on this indirect pathway, which is inhibitory to movement, it results in a net increase in movement. The pathway is shown here schematically, where input from the cortex to the striatum is excitatory, has an inhibitory effect on the globus pallidum, which has an inhibitory effect on the thalamus. The impact of these two negatives results in excitation through this pathway to the cortex. So the whole pathway of the direct pathway is excitatory. If we go from the cortex to the striatum to the indirect pathway, we will see that there's an inhibitory input to the globus pallidum, externa, an inhibitory input to the subthalamic nucleus, an excitatory input to the globus pallidum, interna, and an inhibitory input to the thalamus. These three inhibitory inputs end up with a net inhibition of that by the indirect pathway of movement. However, the substantia nigra, which offers this nigral striatal pathway, provides dopaminergic input to the striatum. And here, the D1 inputs, which are excitatory, dopamine 1 inputs, that is the receptors are D1 receptors, is excitatory to the direct pathway so that it continues this net excitatory input. And in the caudate putamen, there are D2 receptors that get input from the striatum, and they travel along this pathway. By adding this inhibitory input to this pathway in a normal, intact brain, there are 4 negative inputs. They add up to a positive, and they drive movement normally within the cortex. When there's damage to this structure, then this excitatory input is lost, and it's no longer driving the cortex, and the inhibitory input to the striatum is lost, so this becomes inhibitory. As a result, there's a net decrease in movement. We'll see the effects of that subsequently.
The basal ganglia disorders, that is the extrapyramidal disorders, extrapyramidal because the basal ganglia fibers do not themselves pass through the medullary pyramids. They generally result in movement disorders characterized by either involuntary movements, changes in muscle tone, problems with initiating or speed of movement, or difficulty in grading movements, as we'll see. They include hyperkinetic or involuntary movements such as tremor, either at rest or during movements, sometimes postural tremor. They may involve chorea, the Greek word for dance, with rapid continuous movements of face and tongue. And they may include athetosis, these slow writhing movements of the extremities, mostly in the arms and the legs especially. Choreathetosis, which is a combination of chorea and athetosis, or hemibolismus, wild swinging of the extremities. Lesions of the direct pathway result in underactive cortex and reduced movement, hypokinetic disturbance, slowing or absence of spontaneous movements. Parkinson's disease is the classical representation of this type of disorder, caused by degeneration of dopaminergic neurons of the substantia nigra pars compacta. Because the cortex is less active, Parkinson's patients have problems initiating movements, and there's a decreased amplitude and velocity. The symptoms include, there are cardinal symptoms, 4 and a 5th that we'll see in many patients. Cardinal symptoms are bradykinesia, slow movements or very few movements, or even akinesia in the extreme where there's an absence of movements. There's rigidity, with a lead pipe or cogwheel type of rigidity, with much increased altered tone. There's a resting tremor and also impaired postural reflexes. These turn out to be among the most disabling features because people lose their balance if they start to be pushed off balance. And there may also be cognitive deficits.
Parkinson's disease is due to degeneration of the nigrostriatal neurons in the substantia nigra pars compacta. Substantia nigra is the black body, and normally this tissue is all highly pigmented and black, and here we see just a little bit of it, and this should all be black and should be intact. Substantia nigra, that's all degenerated. The cause is a multifactorial, that is both hereditary predisposition, some environmental toxins, and especially aging. But we don't know the distinct underlying cause of most patients. This is a postmortem section through a midbrain of a patient with Parkinson's disease. We see here the crus cerebri, the cortical spinal tract would be here, and we also see the periaqueductal gray.
This shows an MRI in a patient with Huntington's disease. Here's a normal MRI with a big fat head of the caudate nucleus, and here's the MRI of a patient with Huntington disease, and we see a much atrophied caudate nucleus, and as a result the ventricles are somewhat larger. This is due to loss of striatal cholinergic cells. In Huntington's disease, the symptoms of chorea often start late in life, in the 30 to 50 year of age, with very striking movement disorders, but also cognitive disorders and mood changes because of the strong interconnection with these structures of the caudate nucleus with the prefrontal cortex. The disease progression is more pronounced, and you see, as it gets more pronounced, you see progressive loss of function and dementia. It commonly will result in severe dementia and mood disorders as well. The Huntington gene has been isolated, and it's a very strongly dominant gene with now genetic testing is readily available. Hemibolismus is a wild flailing of extremities on one side. It's commonly caused by lesions to the subthalamic nucleus, which affect movement on the contralateral side. And it has relays to the subthalamic nucleus through the globus pallidum and substantia nigra, and the thalamus, the ventral anterior and ventrolateral thalamus, to the ipsilateral cortex. Commonly, it's caused by a stroke in the perforating vessels of the posterior cerebral artery. We see here a lesion near the thalamus in the subthalamic nucleus on the left that caused the right hemibolismus. This is an MRI. Chorea, athetosis, and hemibolismus are all characterized by excessive, uncontrolled, involuntary movements and result from lesions in part of the indirect pathway, which produces an overactive motor cortex. You may see examples of some of these movement disorders under these YouTube locations. Now, the diencephalon includes the thalamus and hypothalamus. Here we'll look at the thalamus. It is the gateway to the cerebral cortex. It contains relay nuclei for sensory, motor, and limbic systems. All of the sensory pathways, except for olfaction, make relays in the thalamus. That is the somatosensory pathway, the visual pathway, the auditory pathway, all travel through the thalamus, synapse there, and then send their fibers up through the internal capsule to the cortex. The basal ganglia, cerebellum, and limbic system also relay in this region. We see here the thalamus deep in the base of the brain. See the midbrain here, so just above the midbrain we come to the thalamus, and we see here the corpus callosum. We're on the medial surface of the brain. This is the interthalamic adhesion, which connects the two sides of the thalamus. And here we see in a coronal section the thalamus on each side of the third ventricle, and we see here the lateral ventricle. In addition to the thalamus, we see the internal capsule immediately lateral to it, and the putamen and globus pallidum. And you see here the thalamus, and you see the hypothalamus just below it. And just lateral to the hypothalamus, we see the optic tracts that come in.
Here we see a schematic drawing of the thalamus and its relationship to various inputs and outputs from the thalamus. We see from the anterior nucleus of the thalamus strong projections to the frontal cortex and some to the parietal cortex. It's heavily involved in emotional behavior. We also see VA and VL, that is ventral anterior and ventral lateral. They are getting strong inputs from the cerebellum and from the basal ganglia, and they send their outputs to motor cortex, primary motor cortex, and premotor and supplementary motor cortex. We see the ventral posterior lateral and ventral posterior medial nuclei. They receive strong somatosensory input from the dorsal column lemniscal pathway and from the lateral spinal thalamic pathway, and it sends its outputs to the parietal lobe, postcentral gyrus, and at the back of the thalamus, we see the lateral geniculate nucleus in purple, which sends its fibers out to the visual cortex. And then we see the pulvinar nucleus, which is an association nucleus, which sends its outputs to parietal and occipital cortex.
We see here some of those nuclei. Don't worry about having to locate within the thalamus individual nuclei. We'll want you to know some of their functions, but not be able to precisely localize them within the thalamus. But we can also see, in addition to the thalamus, of course, we can see the caudate and the putamen and the globus pallidum. And the thalamus is sitting right here. Notice that the fibers, the anterior nucleus travels to the frontal lobe and the cingulate gyrus. That VA and VL travel to motor areas. That VPL and VPM travel to somatosensory cortex. Medial geniculate travels to the auditory cortex, and the pulvinar and lateral geniculate travel primarily to the occipital lobe. Some of the thalamic connections are indicated here. We've just talked about those, going from ventral anterior lateral to basal ganglia, cerebellum, and motor cortex. VPL, a principal input from somatosensory pathways, and spinal thalamic pathways go to somatosensory cortex, VPM, ventral posterior medial, carries information from the trigeminal input, the face, and goes to the somatosensory cortex, medial geniculate to the auditory cortex, and lateral geniculate to the visual cortex. There are a variety of limbic connections that we'll discuss in the future, and recognize that they include the anterior nucleus, dorsal median nucleus, and these have an important role in mood and personality features that we'll be talking about. And then there's some association cortices like the cortical connections like the pulvinar that provide input to both temporal, occipital, and parietal lobe, especially integrating visual information with other.
Coming off of the anterior cerebral artery, the anterior and medial striatal branches of the anterior cerebral artery, and these small branches have an important supply to the head of the caudate nucleus and the anterior limb of the internal capsule. On the other hand, the lenticulostriate branches of the middle cerebral artery, and we see the middle cerebral artery coming in here off of the carotid, and those branches coming off of the middle cerebral called the lenticulostriate arteries because they feed into the lenticular nucleus. They supply the putamen, the globus pallidum, the genu, and the posterior limb of the internal capsule, and the body of the caudate nucleus. A stroke in these branches of the MCA on one side may cause contralateral hemiparesis and a loss of sensation in both the arm and the leg, because all of that travels through the internal capsule, and also contralateral lower facial paralysis because of damage to both the sensory and motor pathways in the posterior limb of the internal capsule and the corticobulbar fibers in the genu. The posterior cerebral artery coming off of the basilar artery supplies parts of the midbrain, including the substantia nigra, which we see over here, and much of the thalamus, and also the inferior temporal lobe and the occipital lobe, so that damage to this artery, depending on its location, could affect both the substantia nigra and produce Parkinsonian symptoms, or produce blockage of information going to the visual cortex and produce a visual defect. The posterior cerebral artery seen here feeds much of the thalamus and also the subthalamic nucleus. A summary of the portions of the brain fed by each artery is illustrated here, and I draw your attention to the posterior cerebral and posterior communicating artery, which feed much of the thalamus, seen here, 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 in the coronal, here in the coronal section as well, and the middle cerebral artery perforating branches, the lenticulostriate branches, here and here, as well as here and here, feeding the internal capsule and basal ganglia, those important structures for motor and sensory function. And then the anterior cerebral artery and the communicating artery feeding the medial portions of the cerebrum, the middle cerebral artery feeding the major portion of the lateral portion of the hemisphere, as we see here, and the posterior cerebral artery feeding the basal portion of the temporal lobe, as well as the occipital lobe. We see the temporal lobe here and here, and we see the occipital lobe coming back. And we don't go all the way back, but it would be right here with the posterior cerebral artery would feed all of this.
And these are summarized right here, where particularly for the internal capsule, because it is such a vulnerable structure, and particularly the posterior limb and the genu, and that is the lenticular branches, lenticulostriate branches of the MCA, affect the genu and corticobulbar fibers carrying motor fibers to the face, and lenticular striate branch in the posterior limb affecting corticospinal pathway, also for the body, and somatosensory thalamocortical projections as well. In summary, the basal ganglia are interconnected structures deep in the brain that modify the activity of primary motor cortex. Damage to the selected portions of this system may produce Parkinson's disease, Huntington's disease, tremor, or dystonia. Damage to the basal ganglia does not produce weakness. It produces these involuntary movements. The internal capsule is made up of information between the cerebral cortex and these deep structures. The posterior limb in particular carries this critical information for corticospinal output of motor cortex, and those are the upper motor neurons, and sensory information for thalamus for specific sensory portions of the cortex. Damage to the posterior limb can produce very profound weakness, that is a spastic paralysis, or sensory deficits, depending on the portion affected. And then the thalamus provides a synaptic relay and processing sensor for all of these structures, the basal ganglia, the cerebellar circuits, as well as sensory inputs from somatosensory, visual, and auditory input, and connected with the cerebral cortex. So damage here can affect many of those functions involved. Thank you very much. If you have any questions, don't hesitate to contact me.